You're gonna do something this week.
Yeah, these are the ones. Yeah. You need a refresher. Or DC100. We can give you that system. Yeah. Thank you. See you. Bye.
I mean, I will. Let me start the Zoom.
Sure, yeah, we just had our we were just at the keep going. Astana, which was 45, and then there's the Alma Ata.
Slide down. Thank you.
Mic check 1 2.
It's a classified like conversation starter.
Yes, but then the links in your
Yeah.
Are you both of us?
Yes.
Quite actually. Yeah. Kidding yesterday. Mostly just attended. Just sat with multiple
Also double check funds, some of our
An African something. Yeah.
Because we have other boating.
Or yeah, where they global lines back in the States. I was working here. I was working for COVID Springs. Another night.
Jason.
Rebranding to stay. It's like friends. It's very like.
I still help produce that kid.
My working class background.
Yeah, almost.
I just muted the video. That's the screen. And then once she...
Oh, okay.
First openings that you've ever heard. Yeah.
I'm sure you get a lot.
Of course not.
Stuff like
Put your email and then you will see.
Yes.
that's always been towards reassessing priorities for diseases. That's why there's different pillars of work. Obviously, one aspect, but then there's also like the NCD plus work, so we're mental health.
Yeah. It's like, are they
That's part of the whole NCD plus. I mean,
Injection. Yeah. Lemon banana.
Yes, and this is
Oh my god, I can hear you. I can hear it up there. Oh, wait. Yes. I'm getting this. See the thing. It's not So it takes time.
Usually it's 2 points, it's just
So 20 minutes for tea and coffee.
okay, so video music is to stop the video, and then when we press this button, we can so when we tap this,
Oh yeah, you mentioned this.
oh, okay, when we do it, then everyone can
Look at this guy.
Okay, to register. Man, yes. Quite interested.
Hi everyone. Hello. First of all, thank you so much for your patience while we were setting up the tech. My name is Leslie Orero, and it's my absolute pleasure on behalf of the Firoz Lalji Institute for Africa to welcome you all to LSC, but most importantly to this symposium and launch event expertly organized by Chris and Elma. But before I continue, allow me to digress just a little bit, ever so slightly, and talk about Elma and Chris. Elma and Chris are not only LSE alum, but for us at the Institute, they're part of the Program for African Leadership family. They were co-directors at this year's Africa Summit, and from the conversations that happened on the summit, they worked to put together this policy brief on advancing health equity. One of our major commitments at the Institute is to support students and the African community here at LSE. And to Chris and Elma, we are proud of the work that you have done, along with all the other contributors in putting together this policy brief. I believe we are all looking forward to hearing your findings and insights from the other presenters. Many thanks and gratitude to LSE's African Health Observatory platform and support from the CDC, who have all joined us for this launch and the panel. Without further ado, allow me to introduce the first keynote speaker, Her Excellency Toyin Saraki, founder of the Wellbeing Foundation Africa. Thank you.
Health Equity in Africa Symposium, hosted by the Firoz Lalji Institute for Africa. I'm Toyin Saraki, founder president of the Wellbeing Foundation Africa, and inaugural Global Health Ambassador for the World Health Organization Foundation. I'm delighted today to join you all, bringing together the London School of Economics and the Programme for African Leadership students, professors, and wider community with leading African policymakers, scholars, politicians, activists, and business people to engage in topical conversations about healthcare on our continent. I join you with a profound sense of purpose and a deep commitment to the cause of advancing health equity across Africa. As the founder president of the Wellbeing Foundation Africa, I've dedicated my working life to promoting health and well-being in African communities, especially in the realm of maternal, newborn, and child health. I'm honored to address you today at this special symposium and also to launch the Health Policy Brief, which is imperative in addressing healthcare disparities in Africa. In the dynamic global health landscape, Africa especially faces a unique spectrum of challenges. Our continent boasts a demographic profile characterized by a rising youth and elderly population. This shift calls for nuanced and adaptive healthcare strategies that will cater to the diverse healthcare needs of our people. Simultaneously, Africa is susceptible to the adverse effects of climate change while only being responsible for a fraction of global greenhouse gas emissions, but suffering disproportionately. This vulnerability is further compounded by economic challenges that cast doubt on the resilience of our health infrastructure, especially in the light of recent pandemics. Despite these challenges, Africa's promise shines through brightly. Nations across our continent are spearheading smart cities, embracing technological advancements, and developing innovative healthcare solutions that are tailored to our own unique requirements. Initiatives like telemedicine, community-driven health programs, and digital health platforms are a testament to Africa's adaptability and forward-thinking approach. At the Wellbeing Foundation Africa, we believe that midwifery is a vital solution to the challenges of providing quality maternal and newborn care for all women and newborn infants in all countries. Through our Mamacare 360 frontline programming and rising from the essential primary health and community tiers upwards to the most fragile neonatal intensive care support settings, WBFA promotes respectful maternity care, nutrition, mental health, clean water, sanitation, and hygiene education, improving health workers' access to modern skills, and informing household behavioural and cultural practices towards reducing preventable maternal and infant illnesses and death in Nigeria, and ultimately contributing to achieving the United Nations Sustainable Development Goals, in particular Goal 3, good health and well-being. Our WBFA midwives deliver classes at the World Health Organization benchmark recommendation of at least 8 antenatal visits in primary healthcare centres, hospitals, and also at camps for internally displaced persons and refugees, where women face around 1 in 13 risk of maternal mortality in their lifetime. Yet despite this, we're proud to say we have never lost any of our over 300,000 Mamacare 360 mothers. This is achieved not only by Mamacare 360 classes, which are taught at a global standard, but also because our midwives provide safe spaces and safe conversations, in person and digitally, when no subject is taboo or off limits. As an extension to the Mamacare 360 program, our digital midwifery service was created to empower mothers with information in relation to pregnancy, labour, childbirth, newborn care, and postpartum care outside of classes, home visits, and community visits. It is an online 24/7 health education and counselling service platform using the most widely used instant messaging mobile application, WhatsApp, for mothers. From reaching mothers in rural and unreachable areas or patients with restricted mobility, our digital healthcare program has evolved to become mainstream and used at all levels of healthcare services. The growth in WhatsApp usage echoes the trend in digital healthcare globally and the need for women and girls to have access to digital technologies for their own health, autonomy, and empowerment. Digital methods for healthcare have proven to be critical for efficiency and effectiveness at the various levels of health landscape and often do save the lives of women and girls. So we must continue to rethink new ways to deliver quality, accessible digital healthcare and services in the most impactful ways to bridge health and gender inequality. The health policy brief that we're launching here today underscores the significance of a synergized approach to addressing healthcare disparities in Africa. This approach involves championing regional and global partnerships, implementing inclusive policy frameworks, and promoting merit-based governance. Our collective efforts can drive transformative change on our continent. The Wellbeing Foundation Africa is committed to fostering strategic public-private sector partnerships to strengthen means of implementation and revitalize the global partnership for healthcare and well-being and sustainable development, while focusing nationally on policy development and stakeholder relations. As we enter what can be described as a defining decade for Africa, a deeper understanding of the interconnections between sectors like security, climate action, and digital innovation becomes indispensable. The central theme of this symposium resonates deeply with me: fostering collaboration and recognizing intersectionalities. We must continue to work together to address these interrelated challenges, acknowledging that our efforts in one area can have a profound impact on another. Our security is linked to our healthcare, our climate action is linked to our health infrastructure, and our digital innovations can revolutionize healthcare delivery. Today, I urge us all not just to discuss the challenges, but to actually commit to finding the innovative solutions and to scaling them. Let's harness the potential of our youth, our bright minds, and our intergenerational wisdom to build a healthier and more equitable Africa. Together, we can turn the promise of Africa into a reality where healthcare disparities are eradicated and the health and well-being of all Africans are prioritized. Thank you, and may our collective efforts lead to a healthier, more prosperous, and equitable future for our beloved continent.
Thank you. I'll now hand over the baton to Chris and Elma to introduce the panel.
Hello, everybody. Just give me 1 minute. Sorry, we're just trying to get the most recent version of this. Hi, good evening, everybody. How are we doing today? Just smile a bit. Your faces are so serious. Okay, thank you so much, first of all, for coming out tonight to listen to this presentation and to support the work that myself and Elma has done with all the contributors that are present. For those of you who don't know who I am, my name is Chris Agape. I'm a recent graduate from the Department of Health Policy, Planning and Financing here at the London School of Economics. And
I'm Elma Luge, recent graduate from the MSc Global Health Policy.
Okay, and together we put together this brief. I'm coming forward because I feel like staying here will just be. All right, but together we put this brief that is focused on advancing health equity in Africa through intersectional collaboration with contributions from Mahmoud Abdullahi, who is also a recent graduate from the Public Policy Department here at LSE, and as well as Meta Sabia Ayele, who is a junior public health advisor at the GIZ AU. And we'll be taking you through the work that we've done so far. Let's go to the next one. And so just to take you on a journey on how this policy brief came about, both of us served as co-director at the LSE Africa Summit, which was themed the Now and Next Generation. And at that summit, we were given a charge by the GIZ AU and Mr. Ibrahim himself, who is here, as young leaders to take the conversations that were in the room to advance policy, to do something with the things that we're hearing. And we took that charge into consideration, and that is what has birthed what we're about to present to you. This brief would not be in existence without the support from the Firoz Lalji Institute for Africa. We have all the wonderful staff here who have continually created an environment for us as young leaders to thrive, as well as the Program for African Leadership. PFALAS, make a noise. Okay, thank you. The Program for African Leadership that has consistently given us 360-degree support while as students and even as graduates. And of course, the GIZ AU, who came on this vision to support what we've done so far. So what was our perspective going into this? We reflected on the discussions at the summit, and we identified significant impacts on healthcare from the different panels that we had at the summit, be it on climate and conflict. We realized that these things impact and affect healthcare, but the connection was not easily or readily seen. And so we decided to go on an investigation that was focused on the evidence of this interconnection right, and the implications of intersectoral challenges in achieving Africa's health goals. And we also decided to say, okay, what will be the appropriate strategy to address these intersectoral challenges effectively? And that sets the stage for how we decided to approach this. And when we look at the world today, we're experiencing what is called a global permacrisis, which simply means that there are concurrent emergencies happening in multiple sectors of the African economy. At the same time, when we look at climate change, there's current water scarcity going on in Africa, especially in the Horn of Africa. Desertation is a big issue. It's affecting agriculture and nutrition. When we look at conflict and security, Africa is a continent with a very high rate of conflict. Just recently, Somalia has now Sudan rather, has now been, certified as the country with the most displaced people in the world. And when conflict happens, there's disruption of health services, violent crimes are committed. We also have, of course, the health emergencies as we saw with the COVID-19 pandemic. And trade is also, playing a significant part of this, because trade restrictions affected the response to treatment that people could get when we experienced the pandemic. And so this permacrisis, all of these things are happening at the same time with significant effects, on healthcare service delivery. And the LSE Africa Summit deliberated on these issues and their impact on the continent. And this brief will highlight the interconnectedness of these sectors on global health and make policy recommendations that we believe can move us forward. So we'll just go through just the introduction I've told you. We'll talk about climate, we'll talk about technology, we'll talk about Africa's evolution and Agenda 2063. We'll talk about healthcare in a globalized world. We'll make policy recommendations and discuss what we think the next steps should be. Let's go to the... Okay, so Elma will take it from here, talking to us about conflict and health.
Thank you, Chris. That was such an interesting overview. So if we talk about conflict, climate insecurity, and health, most times the conversations are isolated. So you would hear things like, well, Africa has 34 countries out of the 54 countries currently in conflict or at the brink of conflict. You see Sudan and DRC, for example, colored in blue, currently have the highest amount of conflict on the continent, and that has sort of led to displacement of communities, displacement of people. You see South Sudan has 42% of its entire population currently as refugees, asylum seekers, and living in internally displaced people camps. Sorry. And then as the colors, the blue gradient reduces, you see countries like Nigeria, Somalia, also in conflict with high levels of displacement, Egypt, Libya, to name a few. Now, with countries like Egypt and Libya, they are at the brink of conflict in the sense that if you look at the Israel-Gaza crisis, they are not in conflict themselves, but they will be affected by external conflicts. So the people in these regions, who is responsible for their healthcare? How are health systems responding to them? And why are we looking at healthcare as a reactionary item versus being proactive about it? Then you look at climate insecurity as an isolated incident as well. Africa doesn't contribute as much to the global north to climate issues and climate insecurity issues, but is currently receiving the brunt of all the climate-related issues, land degradation, erosion, flood. All of these issues have a direct effect on social determinants of health, but when the issues are being attacked or looked at, they are looked at from a more militarized framework, or they are being looked at as, well, we need to go to war or we need to respond with militarized strategy versus how do we take care of people in these regions. So we need to talk about the potential health risk associated with climate and climate insecurity and conflict when you merge them together. What we found was that for climate insecurity, there are a lot of issues with malnutrition, food and water scarcity, and an increase in zoonotic disease prevalence. And we see with the rise of COVID-19, Ebola, SARS, these are issues that when they occur in Africa, we are completely lost on how to deal with them, and people suffer. If you talk about conflicts, there's displacement, which leads to overcrowding in some of these camps. Again, epidemics break out, malaria, cholera, polio, all of these things. You have disruption of health systems, specifically from violence, but then violence destroys health infrastructure, health systems are threatened, and people are out of solutions, right? So what are the results? You see threatened quality of life, violence against women on the rise, poverty, economic challenges, and reverse development. Now, this is extremely significant for Africa because the youth population is about 60%. So if that population is not able to meet up with the demands for development, then we're going to be seeing trends of reverse development. So what can we do about it? We looked at a case study in Darfur, Sudan. This case study was very significant because, as Chris said, Darfur is currently the country with the highest prevalence of conflict in the world. They've been in conflict since the year 2003, so there's been over 20 years of conflict. But the issue about their conflict is not that they are at war. They've been in a colonial system of war that has then translated to ethnic violence, communal clashes that don't necessarily translate to outright war. It's been a consistent system for them. And you see that out of the 9.2 million population, 42% of them are displaced. There's ethnic tensions, political instability, and resource scarcity. They have the highest level of maternal mortality. There are over 13 million children malnourished and in need of aid from Darfur and surrounding regions that are directly affected by the conflict in the region. And then there's increasing violence against women and girls. Now, not to say that nothing is happening in Darfur, because that would be unfair. There are a lot of multilateral organizations that have been raising funds, contributing, and trying to fix the issue. But the real issue in Darfur is not that there's no money being raised or that the issue is not being attacked. The real issue is healthcare is reactionary. All of these issues, when they play out, conflict, climate insecurity, there's no one-stop gap. It affects everything else. But if the solution is attacking the problem in a sense of conflict or in a sense of climate insecurity, then you lose the people and the people that are affected. So why is our healthcare system reactionary? As I said, we need to move the needle a bit. So we're looking at our health system as a structure on its own that should be embedded in multiple frameworks. When addressing an issue on conflict, we should know that the first step is ensuring that we have health systems that are already in place, whether there's conflict or not, and then people are able to access services that helps them to prevent reverse development. So, if we're taking it to a global context, because as Chris said, these things don't happen in isolation. Africa cannot remove itself, and isolate from the conversation. Where do other things come into play? So we talk about conflicts in other regions. The Russia-Ukraine crisis, the Israel and Gaza conflict. What does that mean for people in Darfur and Sudan, especially with the limited resources that they already have? What that means is multilateral organizations would then need to divert funding. Funding that is not readily available will be moved to solve the issues in these other regions, which is fine and it's understandable, but is it fair? How do people get to survive in these regions? And we're saying that we need to have a more holistic approach where the African Union, regional governance bodies take a step in designing frameworks that are integrated for us specifically, solutions by us for us. We can see that there's a humanitarian and emergency relief coordinating plan where we have multiple United Nations agencies attacking these social determinant issues in isolation. If you're utilizing 95 billion on each of these points, solving the same issue, why can't the strategy come together to have one fund that is able to cater to health from a specific point of view, branching out into all of these areas? So we're reducing the excess funding that is being used, and we're creating these solutions tailored to us as individuals and as a community that has a bolstering youth population. We need our governments to take legitimacy seriously, because half of our political issues are framed from illegitimate governments fighting for legitimacy and pushing people to violence and conflict. There's the One Health agenda that sort of tries to drive the three-part system on how we should approach health, but is it African? Will it work for us? That's one of the questions that we hope our panel can tease out. And we talk about emerging markets, new solutions coming, new solutions that already exist. Aside the support from multilaterals, there are other areas that Africa is working on, and I will let Chris talk about that.
Okay, thank you so much for that, Elma. I'll talk about Africa's technological renaissance and healthcare. So what are the prospects and the challenges that technology and healthcare presents for us? So Africa is experiencing a current technological rise. It's evident. reports say $4.2 billion was raised by startups in Africa in the year 2022 alone. And this is an increase of $200 million from the previous year. And there's an expected increase based on a McKinsey report that the African economy will grow by $1.4 trillion by the year 2030 if it continues on its current trajectory. We are seeing the rise of digital cities in Kigali, Zanzibar, Nairobi, Mauritius. These are good indicators for technology. We're also seeing the integration between health tech and fintech with the examples in Kenya with M-Pesa, that is currently enabling people to save, for health challenges. But challenges still exist. Africa still has very low internet penetration, with an internet penetration of 36% when compared to the global average of 63%. 80% of the least connected countries are found in Africa. And there is a very, very prominent digital gender gap where we have 69% of women having access to internet technology compared to 82% of men. So this context, calls for new policies that properly harness the prospect and are also able to address these challenges. One of these policies is the Startup Act, which is currently being signed up by various countries across Africa. Recently, it was signed up in Nigeria. We've seen it being signed up in Kenya. It's in different stages in Ghana and a couple of other African countries where governments are saying, okay, we want to take the lead in setting policies that can harness technological development. Another policy that we can refer to is the AU Digital Transformation Strategy for 2020 to 2030, which has various goals, including having a secure digital market as well as accelerating internet coverage. We've also seen the Africa CDC have established their own digital strategy to increase innovation for emergency preparedness. But significant gaps still exist between these policies and their actual implementation. One of the ways we believe this can be bridged is by leveraging on how other aspects of policy have adopted technology. In Kenya, the Huduma Center in Public Policy enables people to apply for national identification cards easily rather than using the long manual processes. We're also seeing e-birth certificates that can be made available in South Africa and Rwanda. Why can't we have this happen in healthcare? We can leverage technology for immunizations. We can leverage technology for consultation, public health awareness, and not just in the little minuscule efforts we are seeing, but on a global continental level. And then also we see the work being done by GIZ with the African Women in Digital Health, which is working actively to close the digital gender gap. The next thing when we look at technology is considering. The next thing when we look at technology is actually the question of talent, right? And we look at the fact that there's a lot of interest in African talent in the technological space, right? And this is made up mostly of the youth, people like you and I. But we're seeing that a lot of this talent is exiting the continent, and for various reasons. People, they are leaving the continent because they're looking for, better value, better compensation for their skills. But this has two implications. On one front, it means that innovation in the continent may be stalled because our best minds are leaving. But on the other hand, we are seeing that as these talents move to other parts of the world, they are able to bring the African context into the development of solutions in those spaces. And we also see that a lot of the tech solutions that are being developed in Africa are from people who may have left the continent and are willing to give back or return back. So there is need for intentional efforts to harness African talent, both in Africa and in the diaspora, to ensure that we're able to leverage technology to achieve our health objectives. The last thing when we talk about technology is the current rave of the moment, which is artificial intelligence. Now, data is the driver for artificial intelligence. Whoever has the data controls AI. But where is African data being domiciled? Do we have a central place? If I wake up today, I want to get data on African healthcare, on whatever infectious disease. Do we have a central place for collating this data? If we are not at the forefront of championing our own data story, a lot of the biases, a lot of the misrepresentation that we see in the current healthcare space will be transmitted to AI models. For example, in breast cancer detection, it's now proven that AI can significantly accelerate detection of breast cancer. But we know that African women have denser breast tissue and are more prone to more aggressive forms of breast cancer. Are these things being thought about and being, taking note of as we develop AI models in healthcare. So we must develop prioritized data collection and research that are Afrocentric, and we believe AI can play a significant role in consultation and diagnosis. And the last thing, of course, when we talk about AI is the question of ethics. Now, a lot of questions is, is use of machine learning equitable, or is it right, ethical rather, for healthcare? We had just last week, the recent AI Safety Summit here in the UK that has given rise to what is now called the Bletchley Agreement. And out of 27 countries that were present, only 3 of those countries were African countries. It was Rwanda, I think Kenya, and Nigeria. So that shows you the amount of representation that African countries are having in these spaces that are determining these conversations. We must begin to own our own data story. We must begin to rise on the wave to ensure that we are leading when it comes to African intelligence, because that revolution is not going away. I'll be handing over to Elma to talk about visionary frameworks and the persistent challenges.
Thank you, Chris. So, we are not saying Africa hasn't done anything. Quite on the contrary. The Africa Union currently has the Agenda 2063, which is sort of like a framework that's supposed to guide African countries on how to develop individual models that can help accelerate development, or at least measure some of the gaps that exist for solution. We've seen progress in maternal health, reproductive health for women, and for children. But there seems to be deficits in very concrete and crucial areas. There are deficits in food security, health system strengthening, and pandemic preparedness. This is very significant because in the last 10 years, we've witnessed quite a number of pandemics, epidemics, and the likes. And there are projections that there will be more. How prepared are we, and how is this instrument going to shape the future that would hold us safe? Where should the instrument be heading? We think that this instrument should prioritize health, but currently the Africa Health Strategy for 2016 to 2030 lacks the intersectorial focus. We want to be able to answer the question, how can AI be leveraged to enhance food security in Africa, to mitigate conflict and disease outbreaks? That sounds like a long and loaded sentence, but it is possible. We've seen that collaborative action, especially on the international level, brings results. We could see that from the Global Polio Eradication Initiative, where 99% of polio has been reduced on the continent. So it is possible to make health a priority and achieve results. But how are we going about it? Are we trying to look at global models, drag them into our continent, and replicate and think it will work? It's not possible because we aren't built the same way. It's not a one-size-fits-all approach. The Agenda 2063 should take this into cognizance and then begin to develop frameworks that can be deployed across the regions in a way that there's intersections for AI. We're beginning to think through how our data is being stored, how it's being used, and how it's being fed into other programs in a way that we're not duplicating efforts and we're targeting the results that we want to achieve. The Africa Development Bank has been able to put something forward. It's called the Africa Pharmaceutical Tech Foundation, where they are trying to generate 60% of Africa's pharmaceutical needs. This is significant because we saw during COVID-19, when after certain African countries had contributed to COVAX, sharing knowledge, sharing data, sharing property, when it was time to receive the vaccines, there were a lot of issues and we were completely cut off from the conversation. Is it fair? No. Global governance plays a significant role, but regional governance is very instrumental, and how these things are shaped, how the conversations are framed, and how Africa positions itself to be a contributor. We saw that Africa was the largest exporter of agricultural produce during COVID-19, but yet we still continue to face issues on food scarcity. How is that possible? We are not looking at our solutions for internal prosperity. We're looking at our solutions in a very divergent way. And with products like the Africa Free Trade Agreement, we should be able to leverage those tools to build Africa for Africans, positioned in a way that the global world sees us as a force and then brings us into conversations where we're not being misrepresented with AI, where we're not being excluded from our data models, where we're not being told how to run our universal healthcare programs. UHC is currently a trend in the global governance institutions, and they're saying universal health coverage is important. Is it the time for Africa to tap into UHC? Have we provided social welfare programs for ourselves internally where people are able to eat, talk less of giving us free access to healthcare? These are conversations that Africa needs to have internally and come up with frameworks that help us attend to our issues in priority scaling that is suitable to us. These are things that our governments need to talk about when we're looking at health. Putting health as a reactionary item versus a proactive item continues to keep us in deficit. We say we want to leave no one behind, but as a continent, are we doing that with ourselves? Have the people in Darfur in Sudan been able to curb their conflict challenges? How does that play out in South Africa? How does that play out in Egypt? How are we looping ourselves in as a continent when we're having continental meetings? How much of our conversations are being led from the outside? And how can we ensure that we put stop measures on regional level, on country level, and on a global level to ensure that we are reaching our targets? In conclusion,
Sorry about that.
sorry we're speeding through. We don't want to keep you for too long. We're basically saying that the pursuit of health equity and sustainable development in Africa requires recognizing the continent's unique challenges and strengths. By recognizing intersectional approaches, Africa can lead in shaping the future of global health, ensuring its health agenda aligns with its own vision and aspirations. I'd hand over to Chris to run through what our recommendations are as far as a point-by-point basis, and then we'll let you know what we were thinking as far as next steps.
Okay, thank you very much, Elma, and I'll be going straight into our policy recommendations. Some of them you've heard even as we spoke, and we'll be approaching an intersectional approach even in the recommendations we're making. And first, we're looking at intersection of tech, private equity, and health preparedness, and we are proposing that there be more establishment of health innovation hubs, proper incentivization of tech talent, because we believe we can't leverage technology without the right minds, and both, talent on the continent and in diaspora. Promote public-private partnerships, flexible regulatory framework. We know that oftentimes innovation is led by the private sector, but the government and regional bodies should create a framework that enables that sector to thrive and be able to leverage whatever innovation that is coming out from those spaces. When we look at climate insecurity, technology, and health preparedness, we're recommending that we localize climate-smart healthcare technologies, right, that pays attention to the dynamics and the effects of climate change on healthcare delivery, disaster preparedness response, sustainable climate resilient public-private partnerships, climate change surveillance and adaptation strategy. So when we are tackling climate issues, we are talking about water scarcity. For example, at the Horn of Africa, we are not just thinking about just how to make sure there's water available, but thinking of how that affects healthcare, as we've spoken on previously. We should facilitate cross-sectoral policy frameworks. I'll hand over to Elma for this part.
Sorry, can you hear me? Yeah. So on healthcare tech and governance, we are saying that we want strengthened primary healthcare systems. We want technology-driven telehealth solutions. We think that health governance and policy reforms are key, especially for African countries to be able to accelerate the way that it's supposed to. And we think that public-private partnerships for healthcare are significant, because if we're talking about funding and we're talking about accessing resources, funds are usually held by the private equity firms, and the decision-making is with the government. So there needs to be that synergy and cross-collaboration to be able to meet the goals and targets that Africa needs. In a rapidly evolving global landscape, fostering collaborative, inclusive, and merit-based strategies is a cornerstone to achieving a prosperous and resilient future for all. Thank you for listening.
Okay. Thank you so much. Just before we open the room for questions, please get your questions ready. We've said so much, and we decided that we didn't just want to stop at a policy presentation. What will be the next step? What steps do we want to take, or what are the next steps we think we can take to begin to ace this or move these conversations forward? And we came up with this project, which is something we have in mind, developing a health prioritization framework for resource allocation in displaced persons camp. And basically our hypothesis is that if we have a demographic-based prioritization framework, it can better guide the allocation of resources and provision of health services in a conflict-affected settlement like this one. And our objectives are to design a flexible health resource allocation framework for new settlements of displaced persons, and to create a decision-making tool. And to create a decision-making tool that assists humanitarian agencies, governments, NGOs in rapidly determining the most urgent health needs in this kind of spaces. And we're looking at it in two parts. One part will be research. We're going into these spaces asking the questions, determining what their health needs will be. And the second part will then be developing this framework that governing bodies, government, key stakeholders can then use when allocating resources in places like displaced persons camps. So this is a project we have based off all of the things we've said today, and we're open to collaboration, thoughts, to be able to carry this out. And we believe that it will be significant so that we have something that is research-based that funders and project managers can leverage on when providing health services in these spaces. Okay, thank you so much. We open up the floor here to questions. Thank you.
No, anybody with any, oh, wow.
Much. Can you hear me? Thank you so much for that presentation. You raised many areas, many topics. I wanted to ask you personally, both of you, if you had to just choose one topic that Africa needs to deal with immediately in the next, say, 2 years, which one would that be for you? Because you did raise a lot of interesting areas. Thanks.
Thank you. Let's take 2 or 3. Yeah. Okay, somebody here.
So we're trying to figure out if the microphone is working or is not. Can we get to the microphone?
I think when she spoke, it was quite clear.
Hi everyone. Excellent presentation, Elma and Chris. And I found one of the slides you presented about the different multilateral agencies who have been intervening on the crisis, this conflict crisis in Sudan. Very interesting. And I was asking myself, which is okay if you don't have a response now, to say this inclusive, multi-sectoral, and like united fronts for interventions. Do these multilateral agencies not know this? And if they do, why are they not doing this? Because in many of the forums I have been in, these conversations are recurring. And in some of these panels, you would have some of the representatives from this organization talking about what they are doing. But then, afterwards, by the time you evaluate the impact, you still see duplication of effort, you still see individual institutions, organizations driving their own programs. There is no synergy, as it should be. But they come to these panels and they talk about how it is important to have this multi-sectoral approach. And I'm like, where is it disjoint and why is it not happening? So this is one thought that is just running through my mind. But overall, I find everything you guys have shared very important. And I also like that it is very Afrocentric. We are reminded to bring in the socio-cultural context to what would apply for Africa and how this policy brief would translate into meaningful actions. Hopefully, it can be evaluated over time. Thank you again.
All right. Thank you for the elaborate presentation. I had a lot to process within a short time, but yeah.
It's 8,000 words.
I liked it when you mentioned during your presentation about taking up broad, or should I say, up the ladder policies or concepts, trying to implement them on the African context without proper consideration of our context. And when you cited cases like the COVID-19 pandemic, and all these raised a number of questions. One is the issue of extending service delivery, healthcare service delivery to vulnerable communities, or should I say regions within Africa. You realize that during COVID-19, policies came up to ensure public health, such as regular washing of hands, social distancing and all that. Nose masks were distributed across regions and all that. But you realize that the implications of these policies were context dependent and how effective they were. In Ghana, if you go to East Legon, implementing some of these policies were so easy. When you go to a village like where I come from, well, let me mention Tindom in the Upper East region, you realize that there were rooms that had a lot of people staying in the same room. So a household would have like 12 people living under the same roof. These people could not actually maintain, could not follow some of these policies. And I feel that there is a need for some of these policies to take into regard localized context, even within the African region. And so the question is, how do we ensure equity? It will be bad to say equality, but equity in the distribution of service delivery to vulnerable communities, such that someone that stays at a region or a community that is easier to follow these things, like East Legon, such community, when we go to another very vulnerable community, the same impacts or the same results are able to be realized. Because we are talking about public health, we are talking about all this. So how do we ensure equity in the distribution of these service resources or whatever?
The last two, thank you.
Thank you for the presentation. My name is Jackie, or Wanjiku. I prefer Wanjiku. I have a question pertaining to one of the recommendations that was made concerning private-public partnerships. How do we control the level of interaction between the public and private institutions? How do we safeguard the integrity of governments such that the governments are not influenced towards the ideals or perhaps the ideas that the private institutions want to pass across? And perhaps maybe a comment that I believe that public-private partnerships may not always be the solution to everything. And I think it's also up for discussion in these forums that, we get to realize that and act accordingly and fix things in our continent. Thank you.
Okay.
Okay, thank you very much for that very insightful presentation. But in your recommendations, or bulk of your recommendations has bordered around technology. You've proposed tech in almost every facet of your recommendation. But yet you also shared data on how we are low in terms of internet availability, and also there is a knowledge gap for even the people you want to provide services to on how to utilize technology. So how will those recommendations impact on people in the communities, people who don't have access to this internet? How are you going to apply these recommendations when we already know there's that lingering issue or problem? What else can we do outside technology? Thank you.
I think some of the questions will be answered by the panel. We'll let them handle it. I think I and Chris will just take two, also because we're running out of time. Yeah.
you think is important?
What area would I think is important? I think the area of creating value chains and systems that function in multiple spaces. So that also sort of answers your question in a sense. Just because we make recommendations as separate entities doesn't mean that they can't happen simultaneously. If you're pushing for accelerated development, it means that things are happening faster than they usually would. So that implies that even though there isn't a lot of internet penetration, it doesn't have to remain that way. There could be accelerated development in that sense, and then by default, you can implement all these other strategies. But localizing solutions, answering your question, one of the ways that can happen is localizing solutions. So this is what you're trying to achieve, having conversations with local stakeholders and trying to figure out how to bring that solution home in a way that it is applicable to them would be one way to go about it. And I do know that for some of the multilaterals that go into communities, they try to adopt this approach, but of course there's sometimes knowledge divide, there's language barriers and things like that. To me, it can happen. It's with how much seriousness is it being applied, what institutions or what entities are pushing for it, and how much energy is being pushed into bringing the solution full circle. So I think that it is possible. It just requires a specific approach by actors working together.
Okay, thank you very much. The question on why do multilateral organizations not do this, but that will be adequately handed over to our panel. When you talk about PPPs, let me come to that question. I think the idea between public and is to understand their roles, right? That's the way I see it. The government or the public space is to create the regulatory framework, to create the opportunity for private innovations to thrive, and then to say, oh, this is unethical, this is ethical. But if you don't, and that's the way I see that partnership working together. But if first of all, if the public space or the government or regulatory bodies don't see the private sector as an ally, they may end up stifling innovation. And we've seen it over and over again. Private sector will always be 10 steps ahead from where the government is standing. So it's about the government saying, okay, they are doing this. How do we make sure that, okay, it works out for the best good of the country or the larger society? So I think that's just it. The government makes the framework, and then we allow private sector to keep on innovating within an ethical point of view. Technology, I think she has addressed that nicely. These things happen concurrently. AI is coming, whether Africa solves all her conflict problems or not. So we have to be looking at how we can be solving conflict problems, increase internet penetration, but also preparing ourselves for the technological advancement at the same time. I think that's the best approach. Thank you so much.
So I have sorry, can you hear me? Great. I have a brief comment to share, which interestingly links Jacqueline's question, Martin's question, your question. So as part of my experience, I worked with a health institute. So this was a health chain. So I had maybe when I joined 10 branches, and over the time I was there, expanded to 17 and 23 by the time I was leaving. And the reason why I say it links to the 3 questions is because when the brand, so in Ghana it's called Rabito, in Nigeria, it's called CarePoint. When it started 45 years ago, it was like hospitals it was mainly for skincare. So people go in, etc. And so the technology bit comes in because from 2019 to, let's say, 2021, they recognized that, telemedicine was becoming a big thing. And it was helpful because a lot of people can't pay, but with telemedicine, you can cut the cost. And so to localize context, so what they did was that in some communities, people weren't comfortable. You didn't have the space to build, like, let's say, 16-bed facilities, 20-bed facilities, but you'd find a lot of kiosks. So what they did was that the doctor consults with you over the phone. You see him over video, but it's a store in a marketplace where there are 200 plus people, and the marketplace is where the community comes to. And so with that store, people can walk in when they're there to shop, book an appointment, just right there and see the doctor for 15 minutes, pay less than it usually would be, get a prescription. And so when I think about the intersectorial, I can see, for me practically, I can see how it works. And I think that the experience on the ground, it is so possible. And the beauty of it, bringing in the public, private partnership, is that because they've built and established a relationship. I mean, if you've been in Ghana for over 45 years, you've moved through the 10, 11, 13 regions, you begin to build partnerships, because when you go into the communities, you need to consult regulatory, individuals, etc. And so it was easier to replicate, these like telemedical stores across Ghana and then move it to Nigeria. And the beauty of it was that the founder, his son went to Harvard and he studied private equity. And so he brought that knowledge back. And so now he runs, part of the investment he runs is also focused on healthcare. And they've moved from, Ghana, moved into Nigeria, looking to expand. So it is possible to make it happen.
Thank you. That was a fantastic way to bring it full circle. Thank you very much. We're going to go straight into our next keynote. The keynote speaker we're inviting is very dear to I and Chris. He might be dear to the rest of you at some point, right? Ibrahim Sanusi, he's the head of project Strengthening Crisis and Pandemic Response in Africa, the GIZ office to the Africa Union. He currently spearheads the German cooperation program on strengthening capacities for crisis and pandemic response in Africa, executed by the German Development Cooperation Office to the Africa Union in Addis Ababa, Ethiopia. An international development cooperation specialist, his passion sits at the crossroads of governance, innovative technologies, and fostering citizens' active participation in Africa's transformation. I said Ibrahim was very special because I and Chris he's held our hand through this journey. He's pretty much guided us through the process, worked with us, so much so that he even reviewed our brief. That is pure dedication. So thank you so much, and help me welcome Ibrahim.
Thank you. I didn't review the brief. My colleague, Ong, and Metsabea Ayele, who is one of the contributors, did the hard work. All I did was just look over it. So thank you, Ong. Thank you, Mia, very much. But let me also start by expressing my appreciation to the Firoz Lalji Institute, the Program for Africa Leadership at the London School. Thank you very much for this kind of invitation, and also for the emerging partnership between the GIZ Office to the African Union and the P4 program. I look forward to us building on some of the conversations we've had today. Thank you very much. Let me also congratulate Elma and Chris under the tutelage of Tosin and other colleagues at the P4 at the Institute, working the talk after the successful Africa Summit, which I was coerced to join earlier this year, and which has resulted in the policy brief that we're looking at today. So, though my role here today says I'm giving a keynote, it's a very fancy title, but I'd rather see it as a conversation starter for the panel. That allows us to benefit from a robust exchange. And I think we started. I mean, come and look at the quality of questions after that presentation. I started shivering. Like, am I prepared for this? In Addis, it's 10 p.m. So at this time, I should be watching for Nigerians channels news at this time. But it's important because we need to look at, of course, the points they've made about intersectional approaches to improving health outcomes on the continent. So in doing this, I would like to highlight a few messages, and I'll try and do that very quickly because I know it's late in the night. The first is that, in my view, 4 major issues will influence health outcomes on the continent in the foreseeable future. The first keynote speaker, Dr. Saraki, did speak about, the nature of the next decade for the continent. The first one for me is governance. And I say that in response to the question, in complementing Elma's response on what will be one issue that I think is very important for the continent, and I would say it's governance. I've always argued that you cannot separate the health governance issues from the broader governance challenges that the continent faces. And if we are going to make any significant transformation on the continent in the years to come, we have to pay a lot more attention to our governance systems. A responsive, transformative government is likely to have an equitable and responsible health sector. As we have seen during the COVID pandemic, countries with strong and capable systems, and of course high trust between the government and its people, were able to respond more proactively. Think of New Zealand, think of Rwanda, think of, Singapore, amongst others. The second is economic development. Without a doubt, the scale of the health burden on the continent is such that the progress that we see is still very little compared to the scope of challenges that we face. And you can say that also for the resources available to tackle those challenges. I know there are many reasons, including the oft-referenced issues of bad governance and corruption. The truth is the level of economic development in many of the African countries suggests that there isn't enough resources to finance the health reforms holistically and also provide much needed social protection. And I think the policy brief presentation did speak about, the challenge with social protection on the continent. The African Development Bank says the 4.5 billion in capital expenditure currently made on the continent annually is roughly about 20% of what is needed, $26 billion. So we are, the gap is very wide, right? And we need to close that. Of course, achieving improved health is a costly endeavor, and many African countries have limited fiscal space, and that's the reality. I was looking at a paper. My colleagues have laughed over it quite a number of times today. The paper is written by Gatome Munya and Olalere, and they said 15% of an elephant is not 15% of a chicken. Which means that if we are asking government to dedicate 15% of their budget to health with their current GDP, it is not the same if those GDP levels rise by just 25%. So we have to look at economic development more closely because the continent is not just as rich as we think it is. Perhaps under the soil, maybe, but in reality, you all know it. You all know what the inflation levels are in your various countries at the moment. You all know the level of poverty. I bet that many of your students get calls, people who know you're in London asking you to send them something. This is the reality. This is due to several factors, but most significant among them is the low GDP, like I said, and low tax collection efficiency among countries, compounded by low budget allocations to the health sector. Hope is that the AFCFTA, and I'm glad that the policy brief spoke extensively on that, the African Continental Free Trade Area is a game changer. But there's a lot of work that we need to do to make that work. The gap is, even though we have that decision since 2016, there's a slow pace of progress, right? And I also understand, having worked in the environment for the last, 13, 14 years, I know for a fact that it takes a lot to get consensus at a continental level. You're talking of 55 independent sovereign nations. So the hope is that, of course, with the CFTA also coupled with governance reforms, because this is key. You can, of course, have a very robust intra-Africa trade, but if the governance systems are not strong enough, the question by the colleague from Wanjiku, if I remember very well, about the relationship between the state and the private sector is that you have a very strong private sector that then overpowers the states, as you've seen in a number of countries. I won't mention their names, you know them, right? and then you do not have accountability systems that is able to hold people to question. So this is an important point. The third one, if I have not lost my train of thought, is climate change. Already the impact is very clear. The policy brief spoke about it extensively. Climate health emergencies are on the rise, and it accounts for half of the public health events on the continent. There's a WHO study that says over the last 20 years, climate-related emergencies have been responsible, is about 45% of the health-related crises on the continent. So we can see it in terms of frequent flooding, whether it's in Malawi or it's famine and drought in Ethiopia, Somalia, South Sudan, the entire belt. And this is also driving intra and intercommunal clashes, of course, resource-based clashes in many of those places, and further stressing the health systems. So the challenge here really is our ability to put in place strong early warning mechanisms that helps us to be able to track, these climate emergencies. But as we've also seen, for those of you who pay attention to peace and security related issues, we also know that, it's not enough to have early warning, right? What is more important is the response, right? And with the response, we need clearly the capacity of the state to prevent, and prepare and adapt to the realities when they occur, because they will, right? We've seen them, and we know they will continue to happen. So for me, I think the knowledge, state capacity, and having the adequate human and financial resources is key to make sense of data and then respond appropriately. The last but not the least on this is digital technologies. Technology and mobile penetration continue to revolutionize the African continent. Chris spoke about it in the presentation. We've seen this improvement in the service sector, because now we can do Jumia, we can Konga, we can even ask for Boda to bring our food, and tuk-tuks and all of them. But we've also seen that in financial inclusion in Kenya with M-Pesa, in Nigeria with Trove, Bamboo, and the rest of those platforms that allows us to also access global prosperity, so to say. The health sector is likely to be the next frontier. And health tech is the key. Of course, 2 years ago, 3 years ago, I would have argued it is education, it's edutech, right? But it looks like health tech is taking the front seat at the moment. The health sector, like I said, is likely to benefit from the revolution with increasing focus on health tech and the surge of local innovations, health system automation, access to quality drugs, access to innovative technologies for designing new drugs, amongst others. But despite this, there's still a lot that needs to happen. And I think that's the question my brother was talking about in terms of, penetration versus, our drive for technology advancements. There's a lot that needs to happen to enhance growing investments in genetic sequencing on the continent, drug procurement. About 2 weeks ago, we were at the Africa Health Tech Summit in Kigali, and there were marvelous innovations that were on display by young Africans, many of them really, really improving health access on the continent. Operating environment, Chris talked about it. Clear rules and policies that spur innovation rather than discourage them is very important. And I think that that's an important point. This is where the global conversation also on the AI becomes very relevant. Data, data governance issues, data exchange and transfer, and also the idea around building a one digital market on the continent and what that means. But I must add, and that's where I agree with you, that I personally have a bias for technologies that helps to improve access to primary healthcare, because this is where we have a big problem. People in our rural areas, in semi-urban areas, in urban slums across the continent, where the issue of access for very, very primary health issues cannot access them, right? It's not just price, it's also even physical infrastructure getting there. It's also the cost significantly, and many other things. We must also avoid what I call the digital trap, where we neglect basic things and think like the proverbial carpenter whose solution to every problem is a hammer, right? Technology is important, and like Elma mentioned, we must, do these two at the same time. However, hybrid approaches are still very important on our continent. Extremely important. So what does this mean for us going forward as I conclude? Leadership. We saw this clearly during the pandemic. Strong leadership at the national and continental level, instrumental to the overall strong responses that we saw. We also saw commitment to putting in place institutions and mechanisms to strengthen the continent's pandemic preparedness and response. But this should not be an event. Our leadership should not show up when there's a pandemic alone. They should be present in our way of life as a constant, almost like Jesus Christ for the Christians and Muhammad for the Muslims. Strong institutions. Institutions are key. We have seen a great political commitment at the continental levels, creating institutions, the Africa CDC, the African Medicines Agency, the African Pharmaceutical Tech Foundation, the African a lot of all these organizations that have been, institutions that have been created. But we also have to do that not just at the continental, but also at the national and subnational levels. There was a study by the Africa CDC that said that out of the 55 member states of the African Union, only 19 has a legally established national public health institutes. 23 have their public health agenda or topic under either a department in the Ministry of Health or in a research institute and all of that. The remaining numbers, you know the mathematics, I'm not the one who does that, do not have any kind of framework. So how do we deal with that, right? Aside from the legal framework, funding and workforce capacity remains a huge challenge. You all know how many of doctors, epidemiologists, biologists, neurophysicists or scientists and all of that who have left the continent in search of quote unquote greener pastures. These are very important. For most MPHIs to be able to function effectively across the function areas, so there are function areas, core function areas for MPHIs. These are all things we need to look at. The other point, and very important one, I think it's the point that Elma was making in response to that question from Wanjiku earlier. No, not Wanjiku, it was the response to the question on what is the one major thing to focus on. We are in a place on the continent where our leaders are paying a lot more attention, well, I've always paid a lot of attention to peace and security for their self-perpetuation reasons, right? But the dynamic today is that there is a huge industrialization agenda. And if we are able to demonstrate the health topic as a socio-economic issue with a very great impact on economics, on social cohesion, perhaps we might be able to get their attention. And this is the framing that is becoming even more important. And the evidence was, presented 2 years ago, or 3, with the COVID pandemic, where we've seen the shutdown and the entire world, the global economic space, is still grappling with the impact of that. So how do we flip the agenda to be able to make a case clearly that if you have constant epidemics, showing up at your doorstep on a constant basis, or perhaps another pandemic, it creates a huge challenge for you as a country. And so perhaps our government begin to spend more on that. Community engagement is key. One of the major lessons we've learned from the routine immunization and also the pandemic is that when people are actively involved, the response becomes more effective and impactful. Citizens' leadership is crucial for ensuring that health outcomes are targeted, responsive, and impactful. We need to implement measures at all levels to enhance citizens' participation in policy making, implementation and monitoring of policies and interventions. But this is also where specialized citizens groups like the civil society organizations and global movements have a clear role in helping ordinary citizens make sense of some of these issues. I mean, for an average person, Gavi means nothing, COVAX means nothing, right? They just want their child to be healthy and safe, right? But Gavi has a role to play in engaging with governments on routine immunization issues, right? Same with COVAX, same with the Africa CDC and the number of all that frameworks that have been created. Lastly, global solidarity. We've seen the outbreaks like Ebola, COVID-19, and monkeypox have exposed inequalities that exist in the global health system. Developing nations face barriers in accessing advanced technologies and vaccines necessary to combat and contain the spread of diseases. In a recent paper titled Africa's Complicated Path to Global Health Equity, Margaret Geapong and Shingai Machingaidze of the Africa CDC argue that dismantling these barriers require leadership from all actors within the global health system. Africa, and I say this, Africa needs to engage the global system on the basis of a new legitimacy. And this legitimacy must be based, I argue, on responsive governance and improved health outcomes. The continent has shown that it can address its own challenges with the right conditions and the access to medical countermeasures and vaccines. We saw it in COVID-19. We saw it. It was very clear, right? We saw it with Ebola in the countries like Liberia, Sierra Leone, Nigeria, responded to it very quickly at the time. Africa has transformative leadership and the capability of its people to come together in the face of an existential crisis. And that's the point I'm making. However, our challenge remains sustaining those efforts. And this is where collaboration with global actors is very critical. There are examples where, for instance, South Africa was in the forefront of identifying the Omicron variant. But what happened? We got punished for it, quote and unquote. The same can be said in terms of access to technologies as we see the debates with the TRIPS flexibilities. So my central message is that, yes, intersectoral approaches are very important. Why are they not happening? That was the other question that came up. Thank God you're in the London School of Economics. You understand the context of political economy. And this is very important, whether it's within governments, so you have silos. Everyone creates their own little corner and don't want anyone to crisscross or interfere with it. And from that micro setup, we have this massive behemoths, whether they're World Health Organization or the Food and Agriculture Organization or and it's a race for resource. And we have to be clear about it. So for us to address it, we also have to be clear what are the incentives that drive intersectoral engagements or discourage them. And that will be my last point. Thank you very much.
Thank you very much, Ibrahim, for that beautiful keynote. We're going to dive straight into the panel, and the reason why we wanted to have a panel is so that we have people who are working in the space and who can shed more light to a lot of the things we said and a lot of the challenges we threw in the room. And I'll just start by introducing the chair of our panel tonight, Dr. Joanna Lewis. She is an associate professor here at the LSE. Please put your hands together for her as she comes forward with a focus on African pre-colonial role in the contemporary period. She's an author of multiple books, and she has a very recent publication on the impact of COVID-19 mortality in minority Somali communities here in London. Dr. Joanna, it's a pleasure to have you. Please, Professor. Professor Joanna Lewis, apologies. I feel like entering the ground right now. Oh my God, I'm so sorry. Apologies. Professor Joanna, thank you so much for coming. Okay. I feel like I need help with the next introduction. Okay. The next person on our panel is Dr. Lesson Conte. Okay. And she serves as the academic director for the African Health Observatory Platform on Health Systems and Policies, often referred to as AHOP, under the WHO Regional Office for Africa. And it's a pleasure to have you here. She's also based here at the London School of Economics and Political Science. Thank you so much for joining us. And we just heard him speak, Ibrahim Sanusi, who is currently the head of project for pandemic response at the German Development Corporation GIZ office to the African Union in Addis Ababa, Ethiopia. Please, let's put our hands together for our panel as they take their seats and lead this conversation.
Well, it is an absolute pleasure and privilege to be here. You want us to go here? Okay.
Go forward. Please put your hands together for them one more time.
Well, I'll say it's an absolute privilege and a pleasure to be here, to be part of this launch. And as it says in the brochure, in the policy document, Africa's promise shines through. There is such a dynamic energy, such a moral imperative, such a wealth of talent jumping out of the pages of this important report. And it's beautifully written and presented as well, by the way. And what Elmer, Chris and Mohammed and others are evidencing here are symbolising that even after the reality check that we've had from Ibrahim just now, what we're seeing is just generally, this report is symbolising, evidencing the way in which African talent, African self-knowledge, energy, dynamism, of understanding how well, despite resource scarcity, despite post-colonial legacies, despite all the so-called brain drain and conflict, that as Ebola showed, as the pandemic showed, that Africans in many ways are way ahead of responding to some of the crises which now the global north is facing with regard to health challenges. So we're seeing in so many ways, despite the problems, despite the huge issues, we're seeing Africa leading the curve in innovation, of smart tech, of being nimble, adaptive, and reflexive, of community-based healthcare responses, being sensitive to cultural issues. And so we're seeing a very emboldened, wonderful vision, I think, that's come through here. And other than putting Chris and Alma in charge of a whole health policy initiative in Africa, which I think would solve a lot of the problems, we've now got to try and build on your excellent comments and come up with some other ideas. So, but we wanted to I wanted to start off really by asking you, and I know, Ibrahim, you talked about this before, but I wanted to first hear from you, is what about intersectionality then? Do you think it's really a goer? I mean, it's a sexy word, and we've seen it laid out here in this report, but the challenges, as we've heard, are enormous.
Yes. So I think it's integral. You can't escape intersectionality. But the question is how and by who, and that's often when I read these things, that in this space, and AHOP is the entity that I work for, a lot of policy briefs and a lot of documents around health systems are, should we say, problem saturated and solution scarce. And so when I read things, I want to be told, what can I do? How can we improve? And that's not because the solutions don't exist, it's that they're not necessarily documented, shared. And so that's really my start point, is well done, because your policy brief is broad, and you've tried to weave together, these intersections. But coming back to your question, I think there's always this, I call it global health bingo. there's these tick-list words you've got to say in every document, multi-sectorial, UHC, pandemic preparedness, if you're going to get anything funded, you know, and it can be quite frustrating, and they're coming around again after 20 years as well, so my bitterness levels just even more and more. But there's no escaping that you can't impact health through the health system alone, and we saw that through COVID. The Ministry of Health was supported, was in sometimes sort of superseded by the Ministry of Finance. They started coming on board and getting things done. The private sector jumped in. And so this idea that the Ministry of Health is the go-to entity is being questioned more than ever at this point in time. Now, I'm not suggesting they're sidelined, in absolutely no way am I, and I think they should be at the table and their voice should be heard centrally. But I think when I find these words intersectional, they are kind of often global buzzwords, sometimes national if the particular ministries have been to global events. But the reality check, and we're doing some of this work in AHOP, is how these things land in community health systems. And they're sometimes organically happening in these intersectional conversations, because the lady, and it's often the lady who's a community health worker, has also got a role from another NGO, something about agriculture. So they are a little bit joined up, but they are ad hoc and they're not necessarily systemic or efficient. So I would suggest that these global ambitions are sometimes rhetoric and they don't land this intersectional. And we have to always come back to how can they and who. And I'm not able to answer that. I think there's people in the room that can answer that and give evidence to that a bit better.
Did you want to come in at that point?
I think it was brilliantly.
Enthusiastic.
I think it was brilliantly said, and the truth is, perhaps in academic settings like this, it's important to interrogate these buzzwords and make sense of them. But like you said, indeed, these things are already happening, and I think that oftentimes what we see at the community level is that people basically just respond to the challenges that they see around them, whether it's in climate change, or is in health, or is in access to education, or is in access to social services and all of that. And how do we ensure that, and to the question around who is supposed to do this, how do we ensure that we create systems at sub-national level that helps to reinforce the good practices that we are seeing? And when you look around the continent today, you can point in many directions, whether it's in South Africa, particularly in the Southern African region, South Africa, Botswana, Zimbabwe, Lesotho, Swaziland, and the rest of them, where, response to HIV/AIDS and access to ARTs and all of that becomes, the structure for delivering other related health solutions to people. And when you look at that structure and how they've also integrated, in some instances, youth development activities and access to socioeconomic livelihood issues within the community as well, you see clearly that the evidence is there, that it does work. Intersectionality or intersectoral approaches does work. Again, like I said earlier, it's the scale, right? For me, this is the big problem we have. The scale, because if you have that going on in Southern Africa, you cannot say the same for the Sahel. That entire belt, that goes from Mauritania all the way to South Sudan. That's where you have a huge population. The median age, I think, is 13 or 14 year. And then you have swaths of young people. I don't know if swaths is the right word to use, I'm sorry. But just a huge population of young people and also adults who don't have the access, and that's where the gap is.
Talking of gaps then, and these swathes of populations that people are trying to reach and desperate to reach, is that why the attraction of technology is so strong in health? And do you feel that there is a contradiction here, perhaps, as some of the audience mentioned, that the pull of new technologies, yes, in certain situations, it's very positive. But for example, the statistic that's in the report about and we heard from Chris and Emma earlier, with regard to the disproportionate access that women have to technology. Is there a danger that women who, I would argue, of course, from a women, peace and security perspective, are going to be vital in this intersectionality ecology, that the key drivers potentially are going to be left out? That would be such a cruel irony. Do you see ways in which that technology can be better harnessed to get to an intersectional health approach?
I guess it starts with first principles, and this isn't unique to Africa, but it's about having people in the room from the get-go, from design to end user, that have a diversity of lived experience, and that's gender, ethnicity, age, and almost schools, because schooling and educational pathways, because across the globe, I would suggest that the elite leaders have been to probably a handful of universities, so there's a collection of thought there as well. So it goes beyond just geography. And so at every stage of that decision making in terms of that technology, being questioned, not having groupthink, and keeping the end user and the communities in mind, helps it land, I would suggest, a bit more successfully.
Excellent. Ibrahim.
Well, as I like to say, if we try to leave no one behind, we should also try to meet people exactly where they are. And we had a clear example of this during the COVID pandemic, during the immunization drive, right? So, we were developing technologies mapping where vaccines were, and then we were stuck with why people were not coming for the vaccine. Of course, the general feeling was that people didn't want to take it because of all kinds of conspiracies and misinformation that was going on. But a simple initiative by the Africa CDC called the Bingoa Initiative, which basically focused on leveraging young people as community health workers, quote and unquote, going into environments where young people mostly converge, whether it's stadia or it's schools or shopping malls and all of it, and providing on-the-spot access to vaccines, was very revealing for us. And the flip side of it, which I'm still not comfortable with 1 year after that intervention, is that there was an entertainment element to it. So we, of course, leveraged the big superstars on the continent in the music and the movies and the micro-influencers or the macro-influencers as well. And I remember vividly, in Lusaka, at one of the very popular shopping malls there, we had this, I didn't know him, but we had this very popular Zambian musician, a few of them, I think 2 or 3, come. And I remember we've been in the mall for 30 minutes or so, and it's just 1 or 2 people, and we practically were canvassing people to take the vaccines. And the moment these individuals showed up, I mean, you could practically ask them to take anything, just for people to take pictures with these individuals, right? And what that taught me is that oftentimes we also have to tailor the intervention, whether it's technology, whether it's hybrid approaches and everything. How do context? We talked about it. There was a joke yesterday between Elma and Chris about the contextual nuances. I hear that is a very popular methodology here, but it's important, right? It sounds like a joke, but it is extremely important. Context matters, right? And I think that, whether it's technology, whether it's hybrid approaches, those are things that we have to look at. But also numbers don't lie, right? Right? It sounds like a cliche, but it is true, right? Between the women population on the continent and the youth population on the continent, we know for a fact that over the next 10 years, the next decade, these digital natives, are likely to help improve, health outcomes if we, so this is the futuristic angle of the digital approach, right? That where we're saying we are onboarding almost every year a new set of generation who are digital natives, and are able to use these technologies, and are we providing solutions that they're comfortable with? My background is in governance, and we see it with elections, right? And people registering for elections. If you improve access to registration and perhaps put the same investment into digital voting and all of that, you're likely to see an increase in the number of young people getting involved in the electoral process, because there's just this ease that comes with sitting comfortably wherever you are and registering for things and getting service done. But also the point around literacy levels, right? That it's over the years, the evidence is just very clear that investments in education for this women population, young women population, and also young people broadly, male and female, has almost a direct link to improved health outcomes, right? Of course, there are other socioeconomic dynamics that we have to look at and variables, but increase in literacy levels, right? Particularly, we saw that with the reproductive rights issues. Where we're talking about if women are empowered to particularly women in rural areas, are empowered to take decisions for themselves about their health, about their sexual, reproductive plans, then you are likely to see an improvement in there. So for me, it's a mix of, well, adapting our approaches. Adaptation is very key. And two is also making sure that we put the investments in an intersectional way in the areas where we know that we're likely to see a great, targeted, we're able to see a great return on investment in many other areas, particularly in the areas of education.
Thank you.
I just wanted to flag another sort of entry point, because we've talked a lot about consumers or the users and, if you like, the demand side. But on the supply side, there's some really exciting things going on. Paul, the lady left now, but someone spoke about earlier a scaled-up technology, and I'm working more and more with colleagues in Senegal, in West Africa, if we're going to get competing on waves. And it's Jude Pasteur Dakar. Yeah. And they are a shining light in terms of having the diaspora come, return, bring their excellence, and start to produce things and manufacture things, and not be passive recipients of technology. And I'm confident that this is going to be a game changer, and it's really exciting. I think we need to sort of hold on to that supply side changes that are happening as well.
Absolutely.
There are really exciting, dynamic things happening, aren't there? Let's hear from the audience then. We're unfortunately running out of time, but any comments, anything you want to add to what we've heard from our experts with regard to some of the challenges, but also some of the success stories? Yes, Anna.
I wonder if there, from any of your perspectives, there's sort of a connection. Oh, sorry. Thank you. In terms of the translation of sort of global structures and the way that funding models, but also power arrangements are kind of structured at the global level. So, for example, in international institutions, the WHO is, I think, if not the only, one of the only international institutions associated with the UN that is payments from country and member states are voluntary. And I believe it's the only one. And so that means the WHO, at the global level, health is deprioritized as an international concern. You can sort of interpret it that way, I suppose. And the way that can translate into the local level, where WHO's presence is not able to reach communities in the same way, where there may be an absence of state capacity. I was hearing quite extensively recently from some humanitarians about the cholera outbreak in Goma, and the way that the community felt they were failed by the huge humanitarian presence of so many different agencies there on the ground, but the WHO were not to be seen. And all of the humanitarian agencies had their own mandate that they were going to focus on, and they siloed health as a WHO worry. Alternatively, I suppose on the other side, last year I was in Bangkok and there was a brilliant speaker. She's the early childhood head at UNICEF, and she described her experience bringing early childhood health into the fore of UNICEF's mandate and encouraging, saying early childhood health means that children will statistically be healthier for the rest of their lives. At, you know, their baseline health level will be higher. So is there also sort of a way of translating those sort of very local consequences of these global power arrangements and the way that they're sort of structured, especially, like, I guess funding, especially in the case of the WHO? And do you think that it's realistic to hope or want that the WHO, for example, would become better connected into the international system, or that it would, like, I guess the UN system has a better understanding of local context? Like, is that a realistic hope to have, I guess?
Yes, we've got one question at the back, and then I think we'll just have to we'll have to just respond then and move forward.
Thank you so much, Ibrahim, for your thought-provoking presentation earlier. When I first heard you speak at the Africa Summit, you came across as someone who is passionate about addressing some of the deficiencies on the African continent. My question tonight is about some of the leadership of the global health infrastructure. One of the age-old and rather incessant complaints by the African leadership elite has been the lack of or the limited representation of Africans in global institutions. But when you see now, you see that the WHO is led by Tedros, who is an Ethiopian. Winnie Byanyima heads the UNAIDS. Dr. Chikwe heads the WHO surveillance agency. Dr. John Kengasong is now the head of PEPFAR, which is the biggest financing scheme for HIV/AIDS. And a whole bunch of other institutions like Makta Diop heads the IFC, which is the World Bank's private sector financing scheme. So by all means, Africans now have control over massive resources directed toward health response across the world. Now, as a key player in the African health ecosystem, have you noticed whether holding these positions or these strategic professional moves have resulted into any changes in terms of health financing or improving health outcomes on the continent? And secondly, I just want to know if there are actually mechanisms to tap into the skills and knowledge that have been deployed by these important experts, you know, like to immortalize them into institutions that can then be accessed by health institutions from across the continent, or will they just die along with them when they leave these institutions? Thank you so much.
I've had three excellent questions there. Brilliant. Ibrahim, a lot of those points related to you, I'm afraid. So I'm going to turn to you first. Sorry.
Well, I heard my name once. No. Wow. Okay. I should remind myself not to come to NSC. All right. The realities in terms of funding and financing at the WHO is interesting, because you should have a conversation with my colleague on this. I'm not sure whether, you know, there's a telepathy going on, but this was actually a conversation at lunch this afternoon where she was talking about this. I think you're right that we have to continue to show the impact of some of the decisions that are taken at the global level for vulnerable people in many countries. It's not just in Goma. I mean, many of you who are familiar with what's happening on the continent know that for the last 2.5, 3 years, there was a war in northern Ethiopia, Tigray, and it was not just, you know, it's even where the head of the WHO himself comes from, right? And there were huge challenges in being able to respond to the crisis that we saw there. But the bigger challenge is that we are seeing the impact of domestic politics in big countries would drive many of these agendas at international level, and how those high-wired politics impact ordinary people on an everyday basis. I mean, we saw what happened when Trump took over in the US and basically stopped funding the WHO, right? We also know that challenges in various countries, particularly as we saw with COVID-19, but also the crisis in the war in Ukraine, as it's called, basically means that European Union, which is also one of the biggest funders of many of these multilateral mechanisms, is not also able to fulfill its own. And so you see a huge reduction in the budgets available for, and of course COVID just basically compounded everything. So yes, there's a big challenge, and we have to find a way of communicating this. The problem is that politicians are the same whether they are in South Africa or they are here in London or they are in New York, right? Where, to be very honest with you, I just don't think they care enough. That's the honest truth. I just don't think they care enough, and we have to be frank with ourselves. And to be honest with you, this is why I would always say the person who has the first primary duty of care, at least on the African continent, are African leaders, right? There is no two ways about it. My people, where I come from, I'm a Yoruba man, they say that it is the way you market yourself that an outsider would bargain you, right? If you sell yourself cheaply, you're likely not to attract any value from whoever is bargaining. So this is a very important point as far as I'm concerned. Leadership of global health infrastructure, are we seeing change? I think first we have to acknowledge that progress. It's a huge one. I am not sure how much of it is deliberate and structured, meaning that I'm not sure whether we were really prepared for it, right? And do our leaders have the presence of mind to say we are now in a very pivotal strategic position, and they are pulling together to use that to drive? Because you cannot, many of these individuals have just been there for what, how many years? Not up to 10 years now, right? So you cannot undo disparities that have been accumulated over decades, in 10 years, or centuries, actually, right? So what you expect is that beyond these individual achievements, there's also a collectivity that is targeted at crumbling, dismantling, disrupting, right? These systems that have, I mean, the Director General of the Africa CDC, Dr. Kaseya, in a statement when the pandemic fund was the last announcement that was made for the funds, he said it clearly, right? If you already have a bigger percentage of the funds going to other regions and the disease burden is disproportionately on the African side, what are we communicating, right? So the challenges are still there. The progress in terms of these individuals heading these institutions are also important. But I also think that it's not enough yet, right? It's not enough. It's not enough to have people at the political level. Those of us who work in institutions, even universities know that you can have big titles at the top, but the decision making is done on the shop floor. And so who are the individuals who are in those pivotal positions on the shop floor? Yeah.
And there's a double problem as well, isn't there, with regard to politicians these days? How much can they actually do? If we're in this age of portfolio global capitalism as well, how can you call these big global organisations to account? How can you get a health tax on the multinationals that are part of the new scramble for Africa? How can you talk about getting a health tax in terms of reparations as well for colonialism? So it's very difficult, and without that sort of communal activity, that constant bottom-up activity, that's calling them to account is really, really difficult.
And there's a lot of good, and there's a lot of good that is happening, even with those individuals in those positions, right? You're beginning to see a lot more Africa-centric strategies and mechanisms being developed, whether it's the Gavi Africa CDC strategy for routine vaccination that we're seeing. This is one of the direct impact that you're seeing. I mean, John Nkegasong has now moved from, well, not moved, but has also added, as part of his responsibility, the global pandemic diplomacy responsibility, right? And what that means is that beyond just focusing on HIV/AIDS, there's a broader room to be able to also impact on other topics at that region. And I think that this would translate over time. My point is just that we're coming from a very low level of influence, and it would take time to be able to see that impact in terms of results. It's also not instant coffee, sadly.
Yes, a lot of these institutions as well are very elitist in their origins. They go back over decades, and so they're very top down, and that institutional memory of how they should behave in these roles, it's very, very hard to change. I want to give my last word.
I'll be quick. I think this speaks to your question around reaching global to local. I've got a sort of strain of research that looks at that. One example was in Ghana, where we looked at the 1990 targets for HIV. And we were working out whether these global targets had been in the room when we set these for malaria as well. And how do they land in country? Because we talk about top down, we talk about bottom up, but what's the reality here? In reality, are they modelled, aspirational, advocacy tools, and trying to understand? And we found that these grand hopes, they do galvanise people, they do resource mobilise to a point, but whether that's an efficient and a distraction in country, and people then are scrambling around to pitch to align, we found it slightly distorted the longer term, mid-term planning. So I think there is a disconnect there from the global to the local. And by local at that point, actually, we were talking about district level, so we didn't just state the national, because again, there's these tiers, isn't there? And then my final point, and it's such a great question around the leaders of a lot of these global health institutions. They were called out about 5 years ago about who was leading them. Certain people with certain protective characteristics. But I do think, even though these individuals of African origin are incredible in themselves, and you can rest assured then they are more than window dressing. It's to build on your point that they and they alone really can't affect change when you have got embedded in some of these institutions just old ideas of intellectual hierarchy. They're going to be really disruptive just by their presence in these places. And so there's only so much we can hope for them. We can certainly support them in their everyday, but we can't lay it at them. It's upon us and people at all sort of levels of the system also to support change.
Well, I want to thank my fellow panellists for brilliant answers to brilliant questions, so much energy, so many solutions, so much positivity, which brings me back, of course, to the report. And we're now going to officially launch it. So it's my great pleasure to hand over to the authors of the report for a group photograph. And now the report, Advancing Health Equity in Africa, can be formally launched and released into the wild.
That's what you're going to do.
made that point, I hope it didn't get lost. It's jargon-free. We don't want to be
How long?
Oh yeah.
I know you don't want that.
You know what that means? That means that really means we focus on your
I mean, I think you can stop sharing for them. No.
Yes.
Okay, the green is. I feel like I'm rewriting. Yes. Thank you.
Congratulations.
Let's put the. And finally, if I can just trespass on your goodwill a little longer, I want to hand over to my colleague from FLIA.
This moment of fame, let them do their thing.
Sorry.
Sorry.
Thank you so much. Thank you, everyone. Please feel free to scan this barcode. It will take you straight to the document, and you can read it. It's way longer than the presentation we did. It's about over 8,000 words, but we go to delve deeply into all the topics that we talked about. Thank you so much. I'll be handing over to Tosin.
Brilliant. Right, thank you so much, everybody. The only thing wrong with being the last person that gives the closing address is you're the one that keeps everybody from going for dinner. So, and Netflix. So I will not be that person. I'll make it quick. So again, give a round of applause for our speakers. Amazing, and for our 2-star students. Fantastic work. Well done. I always say the only thing better than a great event is a PFL event. PFLers, let's hear it. Well done. So, I was reflecting, I'm just going to kind of try and capture some of my own insights. I've learned a lot today. I've been challenged to even approach the old intersectionality, yeah? Learning. But it also makes me go back a little bit to those of us who grew up on the continent. We know this phrase, health is wealth, yeah? We know it. It's very popular. It makes sense. But actually, the more I think about it, wealth is health. In our continent right now, I think many of us would get to agree that that's where things are at. And that's why things like this are absolutely important and critical. So I'm taking away from me, and I will encourage you all to, like, what are you taking away from today? I think the systems approach to how we are engaged with this conversation is key. I like that they are doing that. And it's interesting when you look at the health expectancy on the continent, that confirms why we need to do something about this. For a continent that is, what, 40% young people, one of the best. If the health is not sorted out, our life expectancy, I believe for male is 61 years old, and for female, I believe it's about 67. Europe, it's I think it's 74 and then 81 respectively. So it's big issues here that you guys are dealing with, and I really applaud you. So for me, I would say that's a big takeaway. It's just thinking about the systems approach, how these things all connect, conflict, poverty, all of that, you know, they all matter. You cannot say you just want to, and you point to me about Ministry of Education, not even having the, I don't even have the resources to even handle it. So how do people like yourselves get involved? So the point you made about leadership and governance is key. You don't need a title, and that's why I have to do a plug for people. I have to. Is being able to create spaces for young people. There's so many events at LSE, so many, and it just blows my mind to see just the level of depth and intellectually stimulating conversation. And the fact that this came out of a summit, and we're here today, is testament to this, guys. It really is. You don't need a title to lead change. and you may not be, you don't need to be at the top, but there's so many events at LSE that if you're passionate about it, go and talk to that person. This cannot just be an event. We need to move from the idea of event. What next? I encourage you to just think, what next? And if you're LSE alumni, you see an event you love, go and engage with that person. I have something. You may not have the answer yet, but go and tell them, I've been thinking about this. I'm passionate about this. Let's move the needle forward. I have a solution. They will support you. And of course, if you're going to come to PFL next year, if you're not an LSE student yet, you're always welcome. So again, thank you so much, everybody. This has been great. And go and have dinner and watch Netflix. Thank you so much.
Oh, thank you so much.
Thank you very much. Thank you very much.
It's not sure. Just reach out to
I stole this.
Yeah, you stole it.
Ask them, can they see it now?
Because I'm not
You are sharing. Yeah.
Because I can't see it.
Do it again. Yes, I mean, go and check now and see. I'm done.
When you come
No, we're trying to bring in, it's going to be a regional platform, so we are trying to invite.
It's not.
Justice, I know happened for 100 years.
Oh, really?
So I am all about it. I'd be delighted.
I will reach out to the bishop and the wrong way out is brilliant. We set up something. Nice to meet you. How are you? Okay, same here.
Maybe share from here. No, let me share from here as a. Or send me the. I can't see that slide that you sent me. I've been looking for it. Do you understand what I'm saying?
Let me email it to you.
So email it to me. This is my outlook. This is my outlook. So you can then. Oh, thank you so much. Thank you so much.
No, it's fine, but I want, like, they promised me that they were to hire an admin, so I will can forgive my camera.
This is in small context. You need to say that afterwards. Are you fully Nigerian? Thank you.
Next year we're piloting like this.
Oh, yeah.
Thank you. Yeah. Chris has a whole policy brief.
Like after
And I'm in the fashion of like case studies. Like those things are like what? But like the managing like the schedule.
So much, like so much because she has internal yeah, she has internal. So most of all the LSC annotator, you can get more.
Yes, it's not our own.
So
Yeah,
just so
yeah, I think that today we decided that the trainings, like even like the slides are in English, the ones that are face to face, with the slides in English, and they're not talking why they're like mainly just thank them. Yes, they have one course, a couple of courses in French. Better the devil you know.
I did that one time, but then I had
Very dapper.
Exactly. This is what
Sorry.
I need my picture.
Should I come out?
Yeah, I get it.
I'm questioning.
I think
A lot of love. Yeah.
Yeah, they promised me that people are surprised that they cancel the test.
Well, it's better that you know it. Yeah. Like cool.
Why is it so?
I'm sorry.
They ask me how
How are you? Look at this cute. He has Manchester. What number? Yes. Oh, really? Okay, you just came like that.
You can book office hours.
Oh, I didn't know that.
Before I was practicing with somewhere else, so I hadn't lived at home since before uni. Right now, I think this is my first time back. Since the age of 18. Who doesn't feel for them? Honestly, I told my parents, I'm like, next year I'm moving out. I told them, like, listen, I'm moving out of this house. I'm leaving. I told them that next year.
Sorry, can you hear me? They're networking drinks outside, please, so they don't roll our drinks back. So please, let's take the conversations out of the room. There are a lot of nibbles, wine, to stay comfortable. Thank you.
Please, come with me so I don't look like I just went by myself.
If I come from the AU and I tell you, oh, you say you 50% of the project, and I tell you I actually don't get that there are no incentives, right? So it becomes a big moral suasion and persuasion and
How are you? I can take any. Pick them up, pick them Exactly, yeah, it's not telling her to take a day off.
Let's go.
I told you I'm going to be here all the time. There's drinks, food outside, very interesting.
Otherwise, I stay in the city, right? And then I call them. Okay. Okay, I can come next week. Between them and next week.
What does Fadil do to you now? Fadil is your best friend.
Sorry, are you okay?
Yes.
I don't know if that is
Everybody needs help, but you know how we destroy that.
I think you were still taking
the last time I destroyed that.
there's drinks, food,
Yeah, well, let's do have
Please, when you said dinner, was the dinner on you?
So,
you wait now.
You said
Wait. You're the only one that heard that one that is waiting. Thank you for coming. Thank you so much.
Hello. Fantastic question.
Oh, I mean, I don't understand. Are you serious? Yeah, like your question, your body language.
It's really, you're very comfortable.
No.
I come from a place of
It's DV491.
Are you in a class?
No.
Okay.
Well, on a live document editing for submission. Yeah, I wrote it just online. I think it's the final draft.
But then we collected millions of naira, the same money that can be repurposed for.
Oh yeah.
Because people don't see you. I mean, of course, they're
Oh,
shopping.
you know, you're my special one. I'll save time for you.
Because it's not paying for the land, it's not whatever.
I've not caught up with you for a long time. How you doing? Talking about that. I try. Oh, you. I owe you guys a special post on this. I'm explaining to you. So I want you.
Set up a.
Yeah, it's on this agenda.
Join Kovacs and Davi and the rest of them.
Actually, my
And
set
leave the below content
set
speaker.
up like a launch.
What's about custom breaks?
Stop it.
That project we need to do.
That way.
How it contributes to
what is happening. Fantastic. That's good. So basically, so the that's all I can ask. I mean, I'm not going to ask anybody to self-sacrifice themselves. They're very fast. God knows so we got about 22. I was hoping it wasn't going to be more than that. I didn't want it to get to, so which is good for a start. It must not do the don't escape. Because you really have. It was meant to be. I think I told you about did it come. Okay, doesn't matter whether they are all immediate or those organizations. When that was so it was meant to come the German government gate. He taught Steve Gates. Steve Gates was the one that taught the other the American professor, current minister of supervisor. So that's why they have it's coming. Putting Nigerian on it's coming. Like people, we don't know anything. So I just started to explore. So Leslie is talking to them. Who's even better? How we can face. I just wanted to help with the banner. You know, I always destroy banners. So please just help me with that one. So that was looking to be
Almost interrupting the panel.
I come from a place of passion.
So this is it. For me, only reason I think this has been huge. This is one of my comments. I think we wanted more fun in MMD. Not big because they said you can't collect something from Empire, which is great. So that's the part, just so you are aware. So for this year, it's about 22. So there's 4 judges keep assisting. So it's you, William, Sechaba, and I just thought keep it people that know each other and if you get along easy, you can just meet over, go through it all and just find it. Just so we've not giving them any like timing. We just said to be in touch. So I'm giving you guys play around. Sending it to you for the I think 2 weeks is probably. So that's the overview of that one, just in case you want to watch it.
There's a conversation that we had. We did
just amazing, girl. Yeah.
I just told you.
Yeah.
Like, yeah, I'm not happy about it.
I didn't even say anything. Don't say anything. Because of them, they are web personnel just they only put the judges on the put of those 2 judges so that the judges are. So that's on the list. Yeah, so in terms of the theme, so I know that so and I wasn't sure if we could achieve it. So when do you need to go back? Don't tell me you're going to achieve it.
Framing the context.
Hey. So yeah, let's go. So you're going to when you see that walk from this to
all of a sudden it makes sense.
Wow.
What is that message doing?
Hey.
Sorry.
We
leave it to the government. It is your voice.
So have you guys
She has lectured me.
She has lectured you.
Yeah,
in his
Oh, yeah.
You're colleagues now.
Oh, now?
Yeah, colleagues now. This is your GHP alumnus. To shake things up.
Disruptive. Emerging market.
Circle back. Conceptual was
nuances. If you're not entering your paper, you are failing.
Very important.
You understand? They have not started doing
you guys have Dr. Claire this year. When?
Okay, what
Non-static contextual nuances.
Something.
Tangible.
Yeah, there will always be something. You just have to think a lot of it.
Thank you so much. We were standing in a queue to get our turn, and we're like, okay, we need to dive into just listening to the conversation. My name is Goodness Ode, based in Nigeria, and I'm from Cross River State. And I'm doing an MSc in health policy planning and finance.
Okay, health financing.
Okay. What is the planning program?
From Cross River.
It's outside, please. Let's go outside and have some drinks.
With most of what you
I
have
was
shared,
thinking to.
very much like
Since we're all paying out, we can start the chatting.
Okay, there are some of them are here. I
I
mean, is this victory and
Yes, now.
Okay, when
You
say
know how you
victory,
do Chevin community.
yeah, we should hold this casually. My glass is Miss Billion. Oh, yes.
Please, all the Miss Billion. Miss Billion.
Yes,
Can I
darling.
give you my contact so that
Oh.
also lectures can
Of
reach
course.
me? Can
Of course.
Oh,
Of course.
also
It
for
will
also
cost
no,
you.
also for other.
It will cost you in
No, let it not be
billions.
like I'm just. It's
It will
just
cost you
in
in
the
the
billions.
billions.
Elma,
Yeah?
please settle that.
You want me to settle
No,
billion
please
charges?
settle that.
Billion charges.
Please fix
Wait
this.
till you be champion come first. When they
Definitely,
give you
Is it 2 billion charges?
Not me.
Billions.
You want to settle me billions.
No, that's why. Why are we co-authors? What are co-authors about?
Really? What session
should I do?
The parallel session on comprehensive
That's
That's
Let
lovely.
me do. Let's
Are you
try
attending the
something
youth
on.
pre-conference?
I message, that's more perfect. I don't know if it's
Christopher.
still feasible because I was reaching out to Chris.
Yeah,
And
Kaniki.
we're speaking this morning.
No, it's no.
You want to use it on Miss Billion?
No. If the guy responded, but didn't respond now. He actually disappointed me. Yes, no.
I'm happy.
Yeah.
I'm happy that
I got some
good
content.
saved you. Miss Billions, I know that you. I know, yeah. From just our interaction, I know that by the time you put these events together,
I was thinking of doing the real for you.
See, please do it. Miss Billions, do it.
Are you serious?
Yes, do it.
Are you giving me the go ahead?
Go
Give me
ahead.
dramatical.
I need
This is the one
content.
GBK posted.
I need content. Let me
From
follow you.
voiceover. Yes, now that's the voiceover I want to do it.
What?
Do.
What's
Don't
it?
laugh at somebody doing it.
Yes.
Let me show you the voiceover. I want to
Do you do that? That would do that.
It's like you know me because I the second track I was watching, I was like,
That's what I need. That's what I need. I already get the vibe.
You feel it.
I feel the
This suit
vibe.
is so
What
nice.
is
We came to a show house.
I had
I'm thinking
to
of GBK's sister.
intersection. We had to intersectionally collaborate.
I think we did.
I'm really looking
Yeah, actually, I felt
So
really
no,
comfortable.
I think the most conveying message was your actual.
Because if I tell her now, I say, "Ah, it's Nigerian sister."
Because the truth of the matter is
Go and look
that
for her,
everything
tell
you're
her
saying, a
you're
lot of
coming for
numbers,
CPHI, but you're stuck or
a lot of
something.
figures, a lot
Whatever
of
she
very
says, let me
far
know.
things that a lot of people here maybe
I'm not
and not facts that people are interacting
familiar
with.
with.
Monira.
But that's the difference between passion.
Yeah.
That's the reason why I was listening. Because like you can see that it wasn't just like, oh, just come to read, okay, this is what's happening, or this is what we're doing.
Oh, yeah.
And like everybody's interaction with these subjects showed that you at least have a certain level of knowledge about it. Because they ask people questions and you have to answer
that's
them
lovely.
on the spot. So,
I mean,
yeah.
the entire health
that
agencies
kind
in
of
Nigeria
helps the
now have
energy
very
of the-
interesting
Thank
people.
you,
Someone was
Jerry.
appointed today.
Billions. That's my number.
Yes, wait,
Did
did
you
you
say
say
it?
it?
That is my number.
Is it not close in front of it?
That's
No,
it.
massive.
You're here now.
I do hear. Okay.
You are here now.
I
I just wanted to be sure, like, you are here.
Yeah, the
So
one going back to Nigeria. You better humble yourself.
have you found your bag? Have you found your bag?
What's your last name?
People that here.
box.
We gather they find the box for us.
That's what I'm saying. People that have house,
Do you know why
people
I-
that live and breathe.
This insult is not directed in the right place because half of the
Yeah,
box
I mean, again,
It's for you.
everybody has been
Ah,
asking.
Billion, sorry. Things are
So
stake for
this
you.
laugh you're
Chris
laughing
Agape,
is
sign me.
this is an intersectoral problem.
Have I heard that name before?
I don't know.
You.
It's Aja. Dr.
It's
Aja.
the Agape.
Yeah.
Okay, Agape.
Is that a musician that is called something like that?
I sing too. Yeah, I sing too.
It's not you they're talking about.
It might be
You
him.
think I don't do
I
gospel
promise
music?
you, it's not.
You don't believe?
Where's your recording?
Search for me
No,
now.
he does gospel music.
Look at her. Have
Chris,
you
Sunday
searched for
morning,
me?
Sunday morning you see
Have you
Chris.
searched for me?
This is what you see Chris on the internet doing. Hello guys, going straight to the house of God. Have you worshipped today? Have you worshipped today?
I'm helping her life. I'm helping her to be more. I'm helping Elma.
Worshipped, but it's
I'm helping
this one
Elma.
accurate thank you.
I'm helping Elma to be more serious in her walk with God. I'm helping her to be more serious.
He will now back up. Have you worshipped today?
I always do. I always do.
What
Like
is
I
here?
know.
Have you worshipped
TCN.
today?
Covenant Nation.
But if we're not there,
Yeah, we have essential.
but if we're not there,
Chris,
we have
your
essential.
case is upside down. I just want to let you know.
Thanks.
Please search the app. Remove your phone.
No, yes, because of the camera. If nobody will notice, you will. So I appreciate. I appreciate sectional collaboration, circling back.
Mama said that
Okay, so that's
yes.
But yeah, I do have music.
Let me send it to you.
Remember,
do you want to have a drink?
You
know we got drinks.
Let's go out. There are shops outside before they roll out. The LSCK woman, she just stood there with a lot of anger. Wondering why these people they're saying.
It's not like I have anything to do with the report now. You understand? That report, they can't roll it back.
Why you leave me? Why you leave me?
he's still talking with this babe, so I'm safe. I'm safe in your arms. Wherever you lead, show